So it's my pleasure to introduce the next speaker, Professor Joe Kvedar. Joe is an author, editor, advisor, and telehealth evangelist. I think when I started digital health, I'm not sure how long ago, 15 years ago maybe, I used to come to the Center for Connected Health Symposium that Joe was one of the founders of. When people don't know who he is, and there are not many people in that category, I'll refer to Joe as the grandfather of digital health in the US. But I used to get plugged in when I came to see his conferences with innovation and enthusiasm. Today, or rather the last session, we started having serious science. And Joe and I had a conversation over a year ago, and we were talking about evidence for digital health and the importance of people to understand what good evidence is. And Joe was very kind, and he did a presentation at the Digital Health Society's virtual summit, where he started to explain what this was so that researchers understood. When his team at Nature's Digital Medicine started to receive papers, how did they decide whether a paper was good, bad, or indifferent? And that's what he's going to repeat for us again today. So, Joe, please come along. Thank you.
Well, special thanks, Bledden, for carrying the torch with me of the importance of evidence, and I'm delighted to be here and share some thoughts with all of you. It's great to connect with some longtime friends and meet new folks as well. So without further ado, this is an important topic. It's one that I'm passionate about, and you might say evidence is important in any field. What makes digital health special? And I think the answer is this intersection of tech and healthcare delivery. And those of you who've been around this area know very well how those sometimes collide. Tech is, of course, about move fast and break things, right? That's their favorite motto. In healthcare delivery, we don't want to break things. We might break your limb. But it's about the fact that, of course, we're talking about human lives, and we want to be very thoughtful and careful. So that's a challenge. And you find that because most digital health startups, founders, entrepreneurs, are funded by venture capital, and they have a pressure on them to turn their funds around. They're risky investments, and their limited partners could put their money in a money market fund sometimes and do better. So they want to move these companies along. Whereas in healthcare delivery, we're like, put the brakes on, let's study it, let's be careful. So that world collides, and I want to talk a bit about that here for the next few minutes. Also, the other challenge, part of the challenge, is that quality clinical research costs money. And a lot of startups view their cash as king. They'd rather put money into product development maybe, or marketing perhaps, or all kinds of sales staff. All good reasons to deploy your capital in those ways to build your company. And then maybe sell the evidence part short because, again, we're in a hurry, and why can't we just, I don't know, enroll a few people like we did A/B testing, right, in our last company. Why won't it work here? So that's sort of the context of the next few minutes. But as I said, there are two fundamental reasons, and you might do both. You might at least like the second one if you're not that convinced about the first one. The first one is that we're talking about people's health. We're not talking about a new website to buy something. So it should be more thoughtful. You'd say, I don't care, I want to make money. Fine, then. The bottom one is that clinicians are often on the team that you're going to be pitching to, and they do care about this stuff. Most of them are trained to understand what reasonably good evidence is versus garbage. So for whatever reason, you pay attention, and we're going to go through it 101. And people say to me, it's common sense. We have this app, it does X. We put it out there, we just put it out on the internet. People grab it and they like it. That's common sense, it works. So two big problems with common sense. And the first is cognitive bias. And we don't have time to take a journey into the world of behavioral economics, which I absolutely find fascinating. Most of you, I'm sure, are familiar with some of these biases. one of my favorite things to talk about is the placebo effect, which you all know that if I gave half of you a real medication for, let's say, cardiovascular health, and the other half the same pill, but it did nothing, the people who got the placebo, about half of you would get better. So it's not common sense. That's too complicated. And then the idea that those of us who are in the world of companies have conflicts of interest. Let's face it, you can't let common sense guide you. So you have to do better than that. I'm sorry. Now, a couple of stories that I love to tell which illustrate how we can go astray with evidence gathering and this thinking about common sense and shortcuts. So this is the first one. I'm sure most of you know that the Romans coined the term dog days of summer because the Sirius star, the dog star, shines brighter between about early July and mid-August. And they thought that that star must be giving off more heat. That's why they call it the dog days. So we, of course, now know that that's not anything to do with why it's hotter in July and August, but that's what sometimes that kind of thinking will get you. And this is another favorite. This is from Tanzania. Some of the first non-Africans that came to Tanzania had rampant yellow fever. And many of them found out if you hung out by these trees that had yellow flowers, there was a higher incidence of yellow fever. So they called it the fever tree. Turned out it had nothing to do with the tree, but mosquitoes in the water next to the tree are more plentiful, and they carry malaria. So again, this idea that you take two things that seem related and you make conclusions, that's a real caveat emptor for this whole process. So just to remind everyone, the goal of science is to isolate one variable, follow it over time, and then draw conclusions about its effects. Easy, relatively easy, when you're dealing with molecules in the lab or colonies on a petri dish or sometimes even laboratory animals. Not easy at all when you're talking about clinical research with human beings because we're all different. We bring different things to the table. You're going to try to match as much as you can one set against another, but it's never perfect. So that's kind of the challenge. And again, people will try to do, well, the most perfect experiment is X, but that's probably going to cost you $1.5 million and take 3 years. By that time, you'll be out of funding and your venture capitalists will have kicked you out the door. So how can we come to some compromise around this idea of evidence gathering? And this sort of is it's the roadmap, if you will. And the first two observational studies and before and after are the ones that are the most common. You'll see those in the marketplace really commonly. We gave our app to 50 people and they got better. Why is that a problem? Well, there's two reasons. And some of this, I want to spare you the sort of hardcore geeky stuff, but if you take a group of people and you follow them over time, there's this thing called regression of the mean, where sicker people will get a little bit better and healthy people will get a little bit sicker. So that confounds all of these things if you just follow a group of people. And the other, of course, is that especially in digital medicine, where we're talking about these complex interventions, it's not like giving you a pill, it's much more multifactorial. People learn about their intervention as they go along, and that changes their behavior. So you can't take that learning bias away without a good control group. And before and after is just a little bit better than observational. Now, observational has its place, and I'll get to that in a minute. But before and after is just a little bit. That just means you followed a group of people and captured some data on them for a while. Then you gave them the intervention, and you captured some more data on them. And again, that's very much a flawed design, but it can tell you it can be directional for you. The same thing as an observational study. We just gave 50 people this intervention and these things happen. What you should get from that is, therefore, we want to test whether it was just a coincidence or it really made some sense. So common logical traps, and we've already talked about the most common, which is this idea that correlation is not causation. The second one here is that, as I alluded to, digital health interventions, they change subjects in multiple ways. They're complicated. It's not like giving you a pill. You have to download something, you have to interact with something, you have to engage with it. You might have study personnel who want desperately to keep you in because it costs money to enroll you, calling you to say, hey, by the way, you didn't engage. That confounds outcomes. So there's a lot of confounders in that, and that's one of the reasons this sort of before and after study design is fraught. Now, I won't go into detail because I don't want to put anybody to sleep on type 1 and type 2, but the bottom line of that whole conversation is that if you don't enroll enough people, you can have either a false positive result where you say, my intervention worked. See, I had 20 people who used it and 20 who didn't, and the 20 people who used it got a better result. I don't know if that's true or not, because I don't know what the right sample size to tell that was. And there's a way to calculate that. Or, worse for you as a champion of your intervention, you could enroll 20 people with it and 20 didn't and see no effect when there is an effect because you just didn't look long enough and hard enough and enroll enough people. So that's what that type 1, type 2 stuff is all about. And again, there's a way to calculate what your sample should be. It's out there, and anyone who has a health services research or clinical research background can do it for you. So as I said, it's not so much that observational studies are not to be done, it's just that they're only the beginning. They're going to generate hypotheses for you, which you are going to then test. That's what that's about. And then you say, well, let's try it in a small sample. And again, you see, that's good. We saw an effect in a small sample. Now, how big of a sample do we actually need to say if there's a real effect or not? That's a large scale, randomized trial. And that's about as far as we get in digital medicine. We don't typically get to randomize double blind. If you think about double blind, that means, again, I gave you a pill that was, let's say, for cholesterol, and I gave you one that looked just like it but did nothing. And I didn't know which was. That's double blind. We can't really do that with digital interventions. We can, and I've seen some scientists and companies do things where they have a dummy app that doesn't do some of the things that they think are really important for the app that they're testing. That's great if you can put the resources into that. That's as close as you're going to get. But even then, you're not blind to it. The user will be blind to it. Your study staff won't be, and they might contaminate that. So the level of data integrity and evidence we can get in digital health is really the third one on this list for the most part, which is pretty good. Now, I sort of skipped over, I'm going to cover that later. So here's a couple of examples of why evidence is important, and I want to just touch on, it's like skipping stones over the ocean, right? Because we're pressed for time. So this comes up over and over again. Is telehealth of the same diagnostic quality as being in the room with a patient? I can't believe how many times that's been asked and how many times it's been studied. But here's an example of a study we published, that was published in JAMA Open about a year ago maybe or so, which said, yes, if we did this diagnostic concordance, we sort of were able to show, and this is good quality science, and you can read about it if you like. So that's an example. Another favorite is, and this is another, there we go, another favorite, here we are. Is telehealth additive or substitutive? Another favorite, where what we're asking is, well, if we give people more access by electronic means, does that simply mean they'll use more and they'll cost more? And this whole thing, and of course, that's the payers conundrum, right? We were talking earlier about payers. Well, this particular paper, and this one was published in the journal that I'm editor-in-chief, NPJ Digital Medicine, and just parenthetically, it's not just science in there, it's good high-quality science, but there's a lot of stuff, and if you go to the website and poke around, I think you'll all find something worth reading there. I encourage you, it's all open access. In any event, this study was done to show that the addition of telehealth visits to a primary care practice during the pandemic had no effect on overall costs. So again, these are the reasons we gather evidence, to solve these kind of vexing problems. Now, I want to spend a little time talking about low and middle income countries. Bledden asked me to address this. This is a challenge, without a doubt, right? I think people would not be surprised to hear me say that. It's because largely of the way resources are deployed, I think. And if you have the fortune we have in the US to have the National Institutes of Health and the National Science Foundation, or for instance in the UK, the MRC, These are government organizations that fund basic research into these vexing clinical problems, and then so much of that work eventually finds its way into the marketplace that we're privileged to do that. It's much harder when you have, in low and middle income countries, these sort of constraints on resources. Sometimes it's about there isn't a culture of science, which, as I alluded to earlier, it's an important culture to have people who are spending their career thinking about how to study these problems carefully. So it really is a challenge. What are the solutions? And again, I feel a little bit like, give me a break. It isn't, one slide is not a solution, and I know that, but just to be helpful and thoughtful, the idea that capacity development in these countries, that there should be links between policy and practice, emphasis on a systems approach. And these are all, this one and the slide before are from two papers which I've referenced in these two slides. I was delighted to see the digital twin slide from my predecessor, and I too am going to just beat that drum for a minute. The idea that, and it's so powerful, we were talking earlier about the challenge of enrolling multiple people in a study and having a control group, and that complicates things. We can all, when this technology is mature, and it's been around. I mean, NASA's been doing digital twins for a couple of decades. It's just making its way into healthcare, and it's the idea that we can take all that wearables data, environmental data, genetic data, other things about you that you're just throwing off from your mobile device every day, put that into a mix and create a digital twin of you. And with the way machine learning and artificial intelligence is going, we can, of course, predict how that digital twin will do over time. And then we can give you an intervention and see how you do, and you can be your own control. That's where we're headed with this. I don't know, it's going to take 10 years to get there. I'm not sure. It's moving very fast. But that will make so much easier a lot of this randomized controlled trial type environment. So look forward to those days when we can use digital twins in that. And they'll have other uses, of course, as well. So evidence gathering takes time and costs money, and requires open-mindedness. It requires patience. Something I didn't mention earlier was for an entrepreneur to put their intervention out and actually study it. You know, I've often, and I do my fair share of advising startups, they'll say, we want to do a study to get X result, and you have to stop and say, that's not the way it works. If you're doing research, you're looking for an answer that might not be the answer you wanted, but that's why it's called research. So you have to have that open-mindedness, and you have to be willing to use it as a tool to improve your product and not just move it forward so you can make a sale. I think, you know, industry and academia don't collaborate enough on this. We're getting better. Since I started doing this work in the early 90s, it's gotten better, but there's still that, as I said earlier, that sort of dissonance between the two views of the world, and sometimes they're viewed as holding each other up, and I think that's unfortunate. And it's critical that low and middle income countries strengthen their research capacity so they can participate in this activity and make the world a better place. Those are my contact information. Thanks very much.